Good afternoon, everybody. Terrific. Great to have you here. I'm Ruth Katz, Executive Director of the Health, Medicine, and Society program here at the Aspen Institute. Thank you all for joining us for this extraordinary session of Public Health Grand Rounds at the Aspen Institute. We're very excited about today's program and most grateful to our outstanding speakers and moderators, all of whom, on extremely short notice, I guarantee you, accepted our invitation to join us today. Before I introduce our moderator, let me take a moment to tell you about this event. Many of you know that Grand Rounds is a time-honored feature of medicine designed to keep clinicians up to date about scientific and medical advances and to promote excellence in research and practice. This ongoing program here at the Institute, now in its 5th year, borrows from that tradition to advance knowledge about the cutting-edge public health issues of the day. And I think we can all agree that none is more critical than our topic today, the new coronavirus, or, as I just learned moments ago, now has a name, COVID-19. Have I got that right from our experts? There you go. WHO just gave it an official name. There's much to get to, and I don't want to take up too much time now, but just a couple of housekeeping things before we get started. As you can see, we are videotaping today's program, and it will be up on our website within 24 hours or so. It's also being live streamed. Our panel discussion will take about 40 minutes or so, after which the speakers will take your questions and comments, but I would ask that you please wait until you get a microphone and then introduce yourself before addressing the panel. And now it's my great pleasure to introduce our moderator today, Helen Branswell. Helen is the infectious disease and public health reporter at Stat News. She comes from the Canadian press, where she was the medical reporter for 15 years. Helen cut her infectious diseases teeth during Toronto's SARS outbreak back in 2003 and spent the summer of 2004 embedded at the CDC. I guarantee you, Helen really knows her stuff. I know that firsthand. She is indeed among the best in the business. And so we're delighted that Helen could make the trip here from Boston to moderate for us this morning. Thank you, Helen, and of course, thanks to Tony, Nancy, and Ron. We know how incredibly busy you are, and so we are most appreciative of your taking time to be with us today. And finally, thanks to all of you. We appreciate your time for joining us today as well. Helen, it's all yours.
Thanks, Ruth. I'm going to keep the introductions very short. I have lots of questions. I'm sure you all have lots of questions too. So what we're going to do is I'm going to ask some questions for a while. And then at a point later, maybe about 5:10 to 1, we're going to be looking to you to see what you want to ask our speakers. And somebody will be walking around with a mic, and you'll have an opportunity if you raise your hand. We are very, very fortunate today with this panel. To my immediate right, we have Dr. Tony Fauci, who pretty much doesn't need an introduction, but this is not his first rodeo. He's been through lots and lots of infectious diseases outbreaks, SARS, MERS, Zika, chikungunya, West Nile. AIDS, yeah, excuse me. All the way back to 1980. The 1980s and AIDS. And beside him, we have Dr. Nancy Messonnier from the director of the National Center for Immunization and Respiratory Diseases at the CDC. And at the end of the panel, we have Ron Klain, who was the White House Ebola response coordinator during the dreadful 2014-2016 Ebola outbreak in West Africa. So let's get going. Dr. Messonnier, I wanted to ask you a question first. You know, this outbreak, and by the way, maybe I'll give you some numbers to start. As of today, the WHO says there are about 43,000 cases, most of those in China, but 393 in 24 countries outside of China. And the death toll topped 1,000 yesterday, so it's now at about 1,018, again, most in China. We've been hearing from WHO that most of the cases are mild. Based on the data that they've seen from China, they estimate that about 82% of cases are mild, 15% of cases are severe, and 3% require ICU care. But those definitions are very vague to me. Can you give me a sense of what you know in terms of how mild is mild and how severe is severe? And what are we seeing in the cases that have landed in the United States?
Sure, and thank you. I think the important thing as a starting place is that what we do know is that disease can be really severe. We know that, louder? Really? Okay, how's that? Thanks. What we know is that the disease clearly can be really severe. We know that because there have been 1,000 deaths. We know that the more severe disease is in people who are older and people with underlying illnesses. What we don't fully know is the full spectrum of illness. Now, it's common in outbreaks like this that the people who come to light first have more severe disease. And so frequently in the early stages of an epidemic, we actually can overestimate the severity because we're seeing that end of the spectrum. And we have to remember that this is a disease that we didn't know before 6 weeks ago. So I would be cautious in over-calculating case fatality rate based on the cases we know, but also that early on in the outbreak, at least some part of the case definition in China required pneumonia. So what we also don't know, on top of everything else, is how much mild disease there is. How would we figure that out? Well, we could do surveillance, but the mild disease might look like all the other mild respiratory diseases that we see with fever or not, a little bit of a cough. What we would really probably want to do is a serological study where we take people's blood, see if they have antibodies, and then work backward to figure out their symptoms. That's generally how we figure out spectrum of illness. Finally, I would say, it's important for us, among the 13 cases in the United States, there has been some spectrum of illness. A few of those cases were a little sicker, they required oxygen, but in general, all the patients in the US have been pretty well, haven't required tons of excessive care, and actually right now, they're actually all improving. And so based on the US experience and based on the experience of other countries outside of China, a lot of these patients seem to be doing okay.
Before we move off that, can I just ask you, in terms of the US cases, did they all have pneumonia or no?
They didn't all have chest x-ray confirmed pneumonia. In the US, we've been very aggressive at looking for cases, as you would expect us to be when we have an outbreak that is coming into the US. And so we've used a relatively low bar of patients who had traveled, especially to Wuhan, with some kind of respiratory symptom to start looking. And what that means is that we've picked up patients who weren't as ill as well. If we hadn't been looking so hard, we might not have found them.
Dr. Fauci, you've been quite public about wanting more information out of China. What would you like to get your hands on?
Well, I think it relates to a number of things, but one of the things that Nancy just mentioned is that we really need to know the scope of this. I mean, Nancy very cautiously gave you the facts about it, but I think it's pretty clear that when you have something like this and the ease of transmissibility, it is highly likely, but we don't know, but highly likely that the number of cases of people who are minimally symptomatic or asymptomatic are much, much, much greater than the group that we see who present to a healthcare provider because of the surveillance of what they're doing and because of the fact that, as Nancy said correctly, that people with disease tend to come to a healthcare provider. So if we knew a few things, A, what the extent of disease is, what the degree of asymptomatic infection and what the degree of asymptomatic transmission is. In general, when you have respiratory diseases or other diseases like that, that asymptomatic transmission is generally not the major driver of an outbreak. It can contribute to variable degrees, but it isn't the major driver. But it does inform policy of when you're going to be screening and when you're going to be diagnosing.
Right.
You know what, I often use the comparison, even though you got to be careful about comparisons because people tend to think they're similar, they're not. But when you have a disease like Ebola, in which transmission is really only by direct contact with an obviously sick person, that really gives you a real good feel for what the potential for spread is. When you have a situation where someone could be minimally or asymptomatic and spread, that has a real impact on how you make certain policy decisions. So those are the things that all of us have really been wanting to know, as opposed to numbers that are given to you in a press conference, as opposed to numbers that you could actually look at the data. And that's the problem.
Right. So one of the things that is informed by knowing when people spread disease is whether tools like quarantine and isolation are useful in controlling them. If people start to disseminate virus and before they even know they're sick, it's much harder to control a disease. Ron, give us some thoughts about, you were the Ebola czar. You had lots of experience with trying to contain or the plan to contain. How do you think things are going now in terms of preparations within the United States to prepare the United States?
Well, look, I think that it's a bit of a mixed bag. So I think that, one of the key touchstones of what we did during the Ebola response in 2014, 2015 was to let science and expertise drive the response and not let politics drive the response. And I think when you look at some of the travel restrictions that have been put in place by the administration right now, it's very hard for me to see what the scientific basis is. Mm-hmm. Obviously, having fewer people come here means less introduction of the disease. There's no question about that. Mm-hmm. But the policy that's been put in place right now restricts people based on the color of their passports. If you have a blue passport, you're allowed to come. If you have another colored passport, you're not allowed to come. I don't think there's a lot of science behind the color of someone's passport being a determinant about whether or not they're allowed entry into the United States. Okay. So I think we need to, we need to think hard about this travel policy, and is it really science-based, or what's the basis behind the policy? And then secondly, I think it's super important for public officials not to take their credibility very seriously in a situation like this. So if you tell people, we've got a travel ban, no one's coming here, we got this locked down, then you ought to have a travel ban and have it coming here and have it locked down. And we don't. So under the current travel policy, in addition to this oddity of banning foreign nationals but not other people, every day we have planes and ships arrive in this country with Chinese crews. That's a vital part of commerce, it's a vital part of trade. I understand why. I'm not saying we should ban that. But we shouldn't pretend like we've got some kind of travel ban or whatever we're pretending like it is if we don't. And so I think that's a real challenge here.
If I may?
Sure.
I actually think this is a really important point that people might.
I'm sorry, this is not working well. Okay, how's that?
Yeah.
I think this is a really important point, which is that, it's really important for everyone to understand what the point of restricting travel was. And, the idea was not that we could hermetically seal the United States against this disease. We know that that's just impossible in general. And as Dr. Fauci said, if the disease is transmittable by people who are asymptomatic or even just mildly symptomatic, it makes it really clear that we're not going to be able to keep it from spreading in the US. The idea was if we could slow it down, because we felt like it was just moving so rapidly through China that we had a window of opportunity that by acting, perhaps we could slow it down. But that window of opportunity that we've bought ourselves, we need to use, and we need to use it to prepare for the potential for us having a worse pandemic. So this really isn't a let's stop it and then we're done. It's if we could pause it a little bit, we'd buy ourselves some time to work on the rest of our pandemic planning. The US government has been working on planning for pandemics of influenza for years. We have those operations in place. We, with our state health department partners, need to start operationalizing that so we're ready if this does spread.
Before I want to go into that a little bit more, but I wanted to ask Ron something else before we move off that. As somebody who was in the White House during an emergency, who knows about how policy decisions are made, I've been wondering about how hard it is not to do something. The science would suggest that trying to stop the virus from coming here by quarantining people coming off planes or diverting planes or taking temperatures as people get off planes from China is probably not, it's not a net that's going to catch all the cases. But it seems to me that it's very difficult when you're in a position of authority, if you're in government, to do nothing. Would it have been harder to say, we're going to wait. We know it's coming,
Yeah.
and we need to take the time that we have and use the resources that we have to start shoring up our hospitals, to start stockpiling masks or respirators, to do those kinds of things. I mean, the public does expect action at a point, do they not?
They expect action, they should get action. I guess my point would be that the action should be science-based and medically based. And while I certainly agree with Dr. Messonnier that reducing the number of people coming here slows the introduction, slows the spread of the disease here, reducing them based solely on the color of their passport, it just, I think, is not really a defensible policy. We also know that quarantines are a double-edged sword, right? We're seeing this on this cruise ship off the coast of Japan right now, where quarantining all these people in a relatively small space is leading to this cruise ship being the second largest country in the world for coronavirus right now, behind only China. So, you know, these quarantines do have kind of complex effects. Look, I think obviously the administration can't do nothing. Indeed, they are far from doing nothing. That's not my point or not my recommendation. The point is, I think you got to be really careful about what you do. You got to base it on science and medical expertise. And then you got to be candid with the American people about what you're doing and what kind of effect it's going to have. And you can't tell people we button up the country airtight when you haven't and you can't, right? I mean, we live in a connected world. The idea that no one is going to come to this country from the world's largest nation is just an impossibility. It just is, without radical dislocation of our economy. Without, by the way, you know, as two doctors know better than I do, so much of our medical system relies on daily imports from China for drugs, for the PPE we're going to use to protect our people. So, you know, people and goods are coming here from China all the time. That's a reality, and we just need to be candid with the American people about that reality.
Dr. Fauci wants in.
No, I mean, it's the decision was not made lightly to have a travel ban. But when you're talking about travel bans, I totally agree with Ron that you're never going to exclude everybody who could be a risk from getting into the country. But as Nancy said, what we were trying to do was to buy, and you said it very well, Helen, was to buy time. When you think of travel bans in infectious diseases, going back for the now 30 plus years that I've been involved in this, I have been one of the vocal people against travel bans for the simple reason that if you're trying to keep people out of the country during an outbreak, you will never ever succeed in stopping it. The only thing you would do is delay it. Because if you put a travel ban here and then it spreads here, here, and there, people are going to ultimately come in. My first argument with that was an interesting argument that I think is important. When I argued very strongly against not allowing HIV-infected people in the country, because we already had so many HIV-infected people in the country, what sense would it make to say you can't come in from Africa or from England or from Australia? So the purpose was that it is not going to be a perfect, there's going to be leakage. By leakage, we mean people are going to be able to get in. But if we could just slow down the importation, particularly from the epicenter of the outbreak. You're not going to get every Chinese person in a port who's coming in. But Wuhan was the overwhelming epicenter. And the idea was to not let those people come in, because as you know, all of our cases, except for 2, have been travel related. Then the question is about, what about the rest of China? Can we screen? And the discussion that we had on the phone and in SCIFs was, well, wait a minute. If you have an average of 22,000 Chinese coming into the country every single day, can we effectively and accurately tell the American people that, in fact, you're okay? Because it's not. So we thought that just for a very temporary period of time, if we have an outbreak that involves the rest of the world and we get transmission of infection in a sustained manner in this country, then any travel ban makes absolutely no sense. Because why would you want to prevent people from coming in when you already have it? So again, a little bit more of a long-winded way of saying what Nancy was saying, what the principles that Ron said are correct. But what Nancy was saying and what I'm saying is that we just wanted to buy that window of time to be able to prepare better. That was the reason.
And how is that going, Dr. Messonnier? I mean,
It's working.
is the hospital sector really gearing up? Are manufacturers gearing up if they can? And to the point that Ron made earlier about so many goods coming from China, do we have reports yet of drug shortages that might trace back to limits in movement at this point?
Yeah, so I think this is really the point, which is that, people like responding, they don't like preparing, right? It doesn't get people as excited. And so shifting gears to make sure that all the hospitals in the US and all the healthcare industry are preparing is not easy. And that's really where we're starting to work through all the professional organizations and all our connectivity with the healthcare industry and all the other sectors. And if you look on CDC's website, you'll see a whole series of guidances for all of those sectors about everything from what to do about infection control, but also about what to do about PPE. As an example, masks are incredibly important to the healthcare industry. You obviously want to make sure that your healthcare provider is willing to treat you, and of course, they expect to be safely protected. We need to make sure that we're not misusing masks now, so that if we need them later for the healthcare sector as a priority, that we have them. And so we are now starting to have all of those conversations about the general sense of preparedness, both from CDC, but frankly, a lot of the work's going on at the state and local health departments where they're working directly with their hospitals and all the other sectors that you'd expect to get ready for something.
Yeah, if I could just build on that, 2 points I'd make. I think one thing Nancy said I want to underscore here, which is we love responses, we hate preparations. And so, one thing about this is everything about this, though unknown, was absolutely inevitable. And the question is, what have we been doing up until now to be ready for this event? And so, and we've seen this over the course of the past 20 years. We had the anthrax attacks here in 2001. Congress poured a bunch of money for a couple years into kind of getting ready for this kind of thing, and then it kind of died out. And then with Ebola, big fear in the United States, big concern about it. Congress gave us $5 billion to do a bunch of things, and then over the years since then, it's kind of like died out. Now the focus is back on this. So one thing I'd say is, we're here at the Aspen Institute, people focused on public policy. The single best public policy thing we could do would be to have a sustained, consistent set of investments in the kind of preparations that Nancy's talking about, and not have this kind of boom and bust cycle. Every time something's in the news, we go crazy, make a bunch of investments, and then we kind of forget about it. Now, here's a good example of that. So back in 2014, when the Ebola, we first had the first case of Ebola in the United States, we had 3 hospitals in America. Tony at NIH treated a patient. 3 places: Nebraska, Atlanta, at Emory, and out at NIH that could really treat someone like that. And we made a lot of investments. We built a network of what we called Ebola and special pathogen hospitals. Ultimately 60 hospitals that had the training, the equipment, the personnel to kind of deal with that kind of risk. Now, before this coronavirus thing, the funding for that was supposed to expire in May of this year, right? And now hopefully Congress will, read the newspaper and renew that. But, but the point here is that I think that I 1,000% agree with what Nancy said. We obviously, when you have something like this, you have to respond. But the most important thing we need to do from a policy perspective is to be consistently preparing, consistently investing, consistently getting ready, because whatever happens with this virus, we'll be back here next year with another one, or the year after that, or the year after that. And so that's the only sure thing and the only sure answer.
Amen.
In terms of the efforts that are being taken both in the United States and further afield, especially in China, to try to slow the spread, I'm wondering how sustainable you think it is? How long can that go on? I mean, Singapore, which has had quite a few cases, 47, I think, as of yesterday, they're already starting to say that they think they have community spread, meaning they can't trace all their cases back to somebody who was in China. They think that there is some transmission within Singapore. And the Prime Minister, in a very extraordinary address that was posted on Facebook, said there may come a time soon where they stop trying to trace so aggressively because they realize effectively it's out of the box. You know, at what point is it time to say, let's use our resources elsewhere?
When you say elsewhere about not containing but mitigating.
Yes,
Yeah.
exactly.
You know, I think when you get a degree of significant, what we call sustained transmission from person to person to person, multiple generations of infection, then you really, I mean, there's limited resources. Then it doesn't make any sense to put a lot of your resources into preventing outside in and look at both containment, which you'll always be trying to do containment, but mitigation. Namely, how are you going to deal with an outbreak that you already have, as opposed to putting the majority of the resources on preventing an outbreak from coming to you? And I think that's what the leader in Singapore was saying. In fact, we have the same sort of strategy that will be work. Hopefully, we never have to put a full mitigation, because we don't want to have that sustained transmission from person to person. But it would be unrealistic of us to assume it definitely is not going to happen. And that's the message that is very fine line sensitive, to let the American people know that at present, given everything that's going on, the risk is really relatively low. But at the same time that the risk is low, that the possibility of this happening is a real possibility. And that's the reason why we've got to address it.
Maybe just
Explain to me why the risk is low, somebody, because to me, when I look at this virus spreading, it's spreading very efficiently.
Sure.
And I can't see why, like, there's no force field around China.
Yes.
It's not going to stop there.
Again, it's the message. When you say the long range, low risk, right now, should they be frightened about what's going on? Right now, we have 13 people. They're in identification, isolation, and contact tracing. Is there a risk that this is going to turn into a global pandemic? Absolutely, yes. There is.
Yeah.
There is.
I just want to add that I know, because
Yes.
you've been asking me this question for a couple weeks, and you've been asking me this question for a couple weeks, and I think the thing to think about in the U.S. is there's only so much worrying that you can do every day, right? There are 13 cases in the United States.
That's what I
11
mean.
of them had direct contact travel themselves from Wuhan, which is the epicenter of the outbreak. And the other 2 were close personal contacts of one of those cases. We've been, with the health departments, aggressive in looking for spread around these cases as part of a containment strategy. So looking way more than we normally might at a disease like this to see if anybody in the close, medium, outside circles around each of these cases has symptoms, if they've had carriers of this pathogen, and we haven't found it. And so that's why we say right now the risk in the US is low, because we don't see any signs of community spread today.
Right.
But our preparations are because we think there is the possibility of a risk.
Right.
And I would also say that part of the thing that's different about this disease for us is that in the short term, this year, we don't have specific mitigation strategies. Despite all the work, we probably won't have a vaccine before a year. We don't have a specific countermeasure. And so if we're talking about mitigation, what we're going to be talking about is things like social distancing, stay home if you're sick, cover your cough, wash your hands. Those kind of interventions are really difficult to implement in a community. So it's going to be really difficult to move to a mitigation strategy because there's not a specific countermeasure that we can deploy.
Right. I just wonder if, I mean, I take your point, and I understand that you're sort of between a rock and a hard place in terms of messaging. But I do wonder if, you know, stressing that the risk currently is low, and it is currently low, you're not going to catch this walking down N Street.
Unless you do.
Unless you do, until you do. But, you know, between that and the WHO, you know, continuing to stress that they're trying to contain for the purpose of elimination, meaning, maybe this virus can be made to go away in the way that SARS was in 2003. I wonder if you risk effectively telling people this is not something that's they're going to have to deal with in the future. And I think that you have a very delicate balance to
we
hit
do.
there.
And that's why we always follow. At present, the risk is really relatively low. But we are taking this very seriously, and the situation could change. That's what if you'd say, wait a minute, you're really, well, what would it be, Helen, if we got up and said, okay, hi, this is Nancy and I telling you, we're really got a big risk of getting completely wiped out. And then nothing happens. Then your credibility is gone.
What do we want people to do?
Right.
Yeah. So I mean, the way I think about it is, they worry so we don't have to.
Right.
And I think that's right. But I do think that the challenge we have is this. Go back to something Nancy said about the lack of therapeutic countermeasures, the lack of a vaccine on any kind of reasonable horizon means that if this gets worse than it seems like it's going to be inflicted on our healthcare system. And I think the thing we need to understand about that is the complexities of our healthcare system, which I don't need to explain to anyone at the Aspen Institute here. But I will say, my by overwhelming experience as the Ebola czar was that I was the czar of nothing, right? Because we don't have a command and control healthcare system in the United States, right? So we have a system that's part public and part private, that is largely state and local based, that most of the troops in Nancy's army are state and local employees when you get right down to it, right? If you're going to have a big monitoring program or a big contact tracing program, that's not going to be even done by the fantastic people at CDC. That's going to fall on state and local government, And if we have hundreds or thousands of people in hospitals, those beds are going to be provided by private hospitals, public hospitals, state and local hospitals. These two sit at the top of a federal healthcare system that isn't really a federal healthcare system. That's not what we have in America. And so I think the challenge here is that we need to be pulsing that system to get it ready for it in a way that, again, isn't command and control. This isn't like they give orders and all these people go run. And so figuring out how we can, and part of that's also going to require funding. And so I think getting in front of the Congress soon with some kind of emergency supplemental package to try to help these state and local governments that are going to face the burden of dealing with all this work if it gets a little bit worse or a lot worse, and really investing in these hospitals and getting these hospitals ready, that's going to be a challenge because the system moves super slowly. CDC, NIH, super fast. They are the best people in our country. We have great experts, great leadership there, right? But in the end, when someone shows up in a hospital in a small town in the middle of the country, it's a complicated system to work all that. And so I think getting ahead of that part of it is really, really important because it doesn't move quickly.
I had asked you and it got lost in the shuffle. Are there any reports of drug shortages that are related to? No, not so far? Great.
No.
So one of the things you've been hearing is that there aren't really currently medical countermeasures, things like specific drugs for this coronavirus or a vaccine. And one of the things that trying to slow spread of the virus to the United States and in the United States hopefully does is buy time to produce a vaccine. Dr. Fauci, tell us where things stand.
Okay, and this is one that almost certainly when people, they want to hear what snippet of what I say they want to hold on to. So we started working on a vaccine. In general, vaccines that are not on an emergent basis take 5, 6, 7, 8 years to get. That's the reason why in an acute situation, you're not going to just pull a vaccine out of your pocket. So what have we done? Not only we at NIH, but there are a number of other companies, investigators, biotech, but we have a pretty good system at the NIH, and we have a vaccine research center, which is, I think, representative of what you can expect. So from the time that we got the sequence of the virus, when the Chinese put it on the public database, we immediately took the gene out of the protein that we want to use in the vaccine to be the thing that induces an immune response. We put it in a certain platform called a messenger RNA platform, And we're working on it right now. From the time we got the sequence to the time we're going to do a phase 1 trial, which is determine in a human, is it safe and does it at least begin to induce the kind of response you'd like to see? From the time we got the sequence, we will be in humans unless there's a major glitch, which I don't think there will be. I hope there won't be. Within 2.5 months. 2.5 months. Now, however, that's a 3-month period because 3 months have gone by. Then it takes about 3 months to determine if in fact it is safe and it induces. So now you're at 6 months. So now at least you know you have a product that you can test. Then you do a phase 2 trial. The phase 1 is on tens of individuals. The phase 2 is on hundreds or even thousands of individuals. If we take that product, go to a place where there's an outbreak, i.e. China, and do a trial, it would take at least 6 months or 8 months to know if it works. So now you're already a year and a month or so. If it does work, then you have to be able to scale up to make the tens and hundreds of millions of doses. That amount of time is going to be as problematic as getting the vaccine itself going. So that's the reason why we say, even though we're going into a trial in 3 months, and we'll have some data in 6 months, a vaccine as part of the deployable countermeasure is not in the mix for at least a year. So the quickest scenario that I could see is if this really turns out to be bad, which we all hope it won't, that what we do is that when we get to the point of the 6 months of the end of the phase 1, that you proceed, what they say in the industry, at risk. And proceeding at risk means you invest hundreds and hundreds and hundreds of millions of dollars to scale up on something that you hope might work. Get that? So that's the real glitch there. And I think if we start to see the sustained transmission from person to person, I know my colleagues are, I know Nancy is, and Bob Redfield are going to be pushing everyone to proceed at risk, because then the FDA can do an emergency use authorization to start administering something at the time you actually have it available. I know it's a complicated answer, but that's the
that's
truth.
it. That was the answer. Most of the answer I was looking for. Ron, you
Can I
want
just
to?
quickly add two things? So, as the policy person here, there are critical missing pieces of policy here. One is we clearly should have a program that de-risks the at-risk thing that Tony is talking about. We ought to find better ways to do public-private partnerships to try to take some of the risk out of this. We went through this a little bit with Ebola, with the vaccine makers scaling up very, very quickly. A lot of them, to be honest, lost a lot of money on it. I have no brief for the drug companies here. I don't work for the drug companies. I'm not like a drug company fan. But there's no question that a lot of them lost a lot of money trying to produce an Ebola vaccine. And Tony's going to get on the phone and tell these people to do this on an at-risk basis. And they're, Tony's extremely persuasive, but these are going to be hard conversations. And so, we should be doing something as a public entity to take some of that risk down. The second thing is we have a global public policy problem, and that's this. We in America have this way to expeditedly approve vaccines that Tony mentioned. We have the PrEP Act to deal with the liability issues if we go that way, if that's what happens. But globally, we don't have those tools. And it's quite possible that we could develop this vaccine here. Tony could make his phone calls. We could get it through this regulatory process. And there'd be other countries where the vaccine wouldn't be approved, wouldn't be used, where there'd be issues of liability. The vaccine makers would be unwilling to distribute the vaccine because of fear of liability issues. And this is a lingering international policy problem that we need to address, because the day will come, maybe not on this virus, but the day will come when we will have a vaccine quickly made, we will want to use it in other countries, and we'll hit these legal and policy barriers, and lives will be lost. And that's something we could fix.
Okay. So, Dr. Fauci, I was glad to hear you lay out the timeline. I think it's still pretty optimistic. I've covered the development of emergency vaccines before for a long time, actually, and it always takes longer. There's always
Absolutely.
a glitch. And the other thing is, so Dr. Fauci mentioned that the vaccine that the Vaccine Research Center is working on uses a technology called messenger RNA, which I believe offers speed in terms of development of the vaccine.
And scale up too.
Okay,
Right.
but where is the vaccine going to be made? Because you're partnering with a biotech, and I don't believe they have a production line. So my question is, you could end up with something a year from now that looks really good. Where is it going to be made in the scale that the world
Right.
needs it to be made?
That's a very good point, and that's where we're going to have to employ a much larger pharmaceutical company that's willing to do the opportunity cost that they're going to lose to get it. And that's the reason why BARDA, with the Biomedical Advanced Research and Development Authority, which has money to invest in the pharmaceutical industry to take a product that's generally developed by researchers. Yes, it is going to be a challenge to be able to get a major company to do that. And I think for the reason that Ron alluded to, because when we were doing this with Ebola, it was a major vaccine company that got burned, who's now pulling out of that. So that is a challenge, yes.
Yeah, in fact, that there is now a licensed Ebola vaccine, but that took years and years and years. And the company Merck that brought it to license has no hope of recouping the costs that it put into developing that vaccine. And a couple of years ago, I actually wrote a piece. I talked to all of the major producers, and they'd all effectively been burned at least one or two times. You know, Sanofi had tried to make a Zika vaccine, and that didn't pan out. They'd also earlier tried to make a chikungunya vaccine. I think it was Sanofi, was it not?
Right.
Time and again, the industry is asked to step up and produce emergency vaccines in circumstances like this, and then the emergency passes and people don't think they want the vaccine. It even happened during the 2009 flu pandemic, which turned out to be milder than people had feared at the start, and then when the vaccine was ready, people didn't want it. So the vaccine manufacturers have been to this dance before. They go away, you know, having lost money, having given up time that they could have put on other projects. It's a very difficult situation for them. Consequently, if you look at who has actually announced that they're going to do anything at this point, only J&J of the major vaccine manufacturers has said that they're going to try to make a coronavirus vaccine. GSK has said that they'll let somebody else use their adjuvant, which is a compound that sort of boosts the impact of vaccine, which means you can stretch it out and vaccinate more people. But the other major manufacturers have been silent up until now. Do you know anything? Are they going to get in?
No, and that's the thing that it's the issue that we've dealt with, Helen is very well aware of it, is the opportunity costs of these organizations. Because if they're going to shift over and make a vaccine for an outbreak that may not necessarily occur, they're not making a vaccine for the things that they're making their money on. And that is very, very difficult to get someone to do. We've tried, we being the federal government, to make investments. You know, we had long conversations about that. I'll just very briefly say it. Is, in other words, if you're going to get a factory that is not going to ruin anybody's opportunity, so it's doing nothing but staying warm, ready for you to come in and make your 400 million doses of whatever it is you want to make. It doesn't work that way. It doesn't, because the companies that have the skill to be able to do it are not going to just sit around and have a warm facility ready to go for when you need it. When you need it, they're going to have to stop making polio vaccine, measles vaccine, hepatitis vaccine to put your particular product in. You're right. It's very difficult and very frustrating.
So I just raise that because I think we need to be very careful about how many promises people get about how soon vaccine will be ready.
I never promise. I never promised you a rose garden, Helen.
Okay, great.
I'm telling you the timeline. I'm not promising anything. Right?
Okay, so Dr. Messonnier, given that we've established that it's going to be a while to vaccine, and as and this virus may end up circulating here. I mean, what do you think, knowing what you know about it so far, what kind of measures do you think CDC would be looking at? I mean, school closures, there don't seem to be a lot of sick kids with that, and this infection, and school closures have huge implications on families. I mean, what would you look at?
Yeah, this is really difficult. From a CDC perspective, a lot of the work that we're doing on this coronavirus rests on the foundation of the planning we've done for influenza. So because of the threat of pandemic influenza, we've thought a lot about what we would do in exactly this situation when we were faced with a new respiratory pathogen and we didn't yet have a vaccine. And the kind of things that we're talking about is social distancing, that is trying to keep people from transmitting to one another. The school children thing is an interesting question. There are multiple hypotheses for why there haven't been many cases in children, but one hypothesis is actually that there has been, but it's mild illness, and it would be unusual for kids in this kind of situation not to be getting sick. So it's possible that we will find that there is illness in children. Children sometimes are the ones who actually seed their household, and so there might be a situation where we would want folks to think about keeping kids home from school. What's different now than it was 10 years ago when we first really started thinking about this is the availability of teleworking, teleschooling, and telemedicine as ways to keep people from congregating, including in their physician's office. So we're looking at all of those things to come up with how we might operationalize social distancing. The other kind of things that you end up asking are not to have mass gatherings, not to have lots of opportunities for groups of people like this to be passing germs back and forth. And it is hard to operationalize that at a large enough scale. But the truth is, we know that if we do those things, it can work, and it also can buy us more time. When we use mathematical modeling to look at the trajectory of an epidemic, putting in place those kind of social distancing tools keeps it from coming quickly, buys you more time to the eventuality of hopefully eventually a vaccine, and frequently lowers the peak of disease, because what we also don't want is everyone getting sick at once. It'll overcome the healthcare system. So it's not just about preventing it, it's about trying to scale it and time it so that the healthcare industry can manage the patients that we might see.
Best guess what we're looking at here? I mean, one of the problems with this is that, as we heard earlier, there isn't a really good sense of how much mild disease there is. So when people are talking about 2% of patients seem to be dying, that's obviously going to turn out to be wrong. I think it's likely that it's a smaller fraction.
Right.
2% would be a disaster. What do you think we're looking at in terms of case fatality? Would you even venture a guess?
Well, yes and no. I mean, because you don't want something to come out as this is a prediction or whatever. But if you look at the relative mortalities that we have, so right now the mortality, counting just the people who are accessing a healthcare system, is a little bit more than 2%. It was hanging around 2%. It's like 2.2 now, 2.1. SARS was 9 to 10%, but that did not transmit very well. But the thing you really want to compare it to, because we have a lot of experiencing with it, is seasonal influenza. So seasonal influenza is about 0.1% or so. Now, if you look at pandemic influenza, look at 57 and 68, it went up to about 1 or so, a little bit less than 1, a little bit more than 1. And when you talk about the catastrophe of 1918, that was close to 2. So right now, if we're at 2, I believe, though I don't know for sure, Helen, that it's going to be multifold less than that. I think it likely is going to be down to 1 or below 1. I think. I don't know. But I don't know. But I think it's going to do that, because if it's half of 2, that's 1. I think, and I think that And again, if Nancy's going like this to me, be careful, you're gonna have to eat your words. I'm saying, I don't know, but I'm just saying, what is my imagining it would be? If there are twice as many people who are sick, who are infected, either asymptomatically or minimally symptomatic, then you bring it down to 1. If you could bring it down to 1 or below, from a dynamic standpoint, it's very different from influenza, but it would be acting like a really bad influenza season if it were that. A really bad one, not a mild one, but a really bad influenza. That's the possibility. Now, having said that, it could be multiple other versions of it.
Right.
So that's the reason why it's, you could surmise what it's going to be, but I don't know what it's going to be. And that's the thing that drives all of us, is that we don't know because we haven't had prior experience with this particular infection.
I just will add one thing. I'm not going to predict.
I'm not predicting. You give me options.
But another thing that really you need to factor into your thinking is how quickly this rose to high rates of disease, high number of cases in Wuhan. And you can imagine that the healthcare sector in Wuhan was likely rapidly overwhelmed by the number of cases. It probably impacted people's willingness to seek medical care. It may have impacted the ability of the healthcare sector to provide optimal care for everybody. And so we also don't know how much of those deaths reflect the societal disruption that's happened to the unfortunate citizens of Wuhan, and whether, again, by giving ourselves more time, being able to slow the pace of it, whether it will help us in the eventuality that we need to care for these patients.
I think if we have questions from the audience, this would probably be a great time to start. We have one down here.
Yeah, if you wait, we've got microphones, and if you would introduce yourself.
Let me thank the panel for a really interesting conversation. I'd like to talk a little bit about the politics, Dr. Fauci and Ron. Is there an interagency process? I'm sure there was during the Obama administration, but is there one now where you have some line of communication between NIH, CDC, the Defense Department, Homeland Security? We have sailors who wanted to get into Hong Kong, couldn't, but they might have, and might have become infected and come back. So all of these agencies would be very much involved from a national security point of view. So first issue, is there a really good interagency process? Second thing to you, Ron, in particular, have we a public affairs strategy, namely that we have a warm policy whereby we know when something like this happens, here are some of the parameters we have to operate within. And then to have that, and you can adjust it up or down, but also does it deal with social media? Because social media is where most of the extreme conspiracy and other types of things take place. So within the interagency process, is there a way to plan on having a real strategy that can be implemented to counter that and to spread good information, whatever you have, from a trusted source? Now, when you get into trust, that's a whole different issue in terms of the administration, because the president has said it's over. It's reached its apex at this point. So I think there has to be something within the government that communicates to each other, but also has a real public information policy.
Okay, Dr. Fauci first.
Yeah, so what we have is in the Department of Health and Human Services, the effort is clearly led by Secretary Azar, which involves CDC, NIH, FDA, Aspen, BARDA, et cetera. But we also frequency, and when I say frequently, I mean like really frequently, every day at least, sometimes twice a day, have a meeting that is generally chaired by the National Security Council. And we do that, and that's the interagency. It's a PCC, which you're very familiar with. You've been in many. A PCC that we have at least once a day and sometimes twice a day. We have one at a lower level. Every once in a while we get the deputies there, and it involves the interagency. So and right now we also have put together the coronavirus task force, that includes individuals from the different agencies. So there's an extraordinary amount of communication, literally on a daily basis,
In terms of the social media thing, you guys are doing something at least with Twitter, because I know that if you search coronavirus on Twitter, right at the top of the page, the first thing that shows is a message about looking for good information sources and check the CDC.
Yeah, so my day job is working on vaccines. And so clearly with issues around the United States of misinformation about vaccination spread through social media, when this outbreak first evolved, it was clearly important to us to make sure that we do what we could to at least make sure that technically correct information is highlighted in social media. And because of the background work that we've done, Pinterest, Facebook, and Twitter, at least those three, all have, if you search, the top line sites and the top line information is well curated information from CDC. I think that's a success. Unfortunately, if you read farther on, you can find misinformation, but at least they're leading with stuff that is scientifically credible.
Ron, did you have something?
So just quickly, I'd say, number one, I've said this publicly before, I've written about this. I think it's a mistake that President Trump has not named someone at the White House to coordinate the response on this on a full-time basis. After the Ebola response in 2015, we recommended to President Obama that we set up a permanent unit in the National Security Council, a global health security unit led by a director of pandemic preparedness. President Obama accepted that recommendation. That continued through the first year and a half of the Trump administration. When John Bolton took over the NSC, he disbanded the unit, sent its head back over to USAID. I think that's missing. Why? Not because Secretary Azar is fantastic. He is. Not because there aren't great people working on this, a lot of interagency. There is. But in the end, if this is going to be a whole of government response, it's got to really be run out of the White House. And then there's also a lot of international points of contact, and the people around the world need to know who they're dealing with. And I think that's a weakness. I think on this social media thing, I think what Nancy and her team at CDC have done to try to cope with social media is much better off than we were a couple years ago. But this is a place where public health is just behind, right? It is not a coincidence that information that spreads quickly on social media is called going viral, okay? This is one of the great sources of risk of our time. The ability of misinformation to spread quickly and without the ability of experts to really control it and press it down. We saw a little bit of this during Ebola in 2014. Social media is much bigger now 5 years later, and I think this is just a huge challenge for the public health community.
There's a lady right there.
Excuse me, one second. I'm going to ask, we've got a lot of people want to ask a lot of questions. I'm going to ask people
Very short.
to the point so we can try and get as many.
Sure, and one, please. One question, please.
Regarding this international response coordination needed and so on, I'm mystified, and could you comment on China's declining, refusing WHO, US, whatever assistance? Thank you.
WHO is in China now. They've sent a mission.
Right. WHO has sent an advance team mission there with the thought of having more people. We have made it very, very clear that we would like very much to get a team of our own people there, both to assist the Chinese, as well as to have our own eyes and boots on the ground to see what's going on. At this point, as of last night, we have not yet gotten any notification that our people will be able to go there. Of note, the CDC has a permanent office there. The question is, they're not yet allowed to go in and essentially be embedded in the response. Hopefully, we'll see a change in that right now, but right now we don't have people there.
Lady right there.
Thank you, Si Yang from the Voice of America. I have a question about influenza and coronavirus. The reason I'm asking because the spokeswoman from Chinese foreign minister wants comment on the U.S. travel ban. She was saying China, the United States, the influenza in the United States caused more death than coronavirus. So as a result, my friends from China sort of calling me, say, hey, the outbreak of influenza in the United States. So my question, can we compare this together? I mean, the coronavirus and influenza. And just wondering what's your expert's point of view here. Thank you.
Both
I
are
think
bad.
there's two ways to compare that, right? So one is, if you look practically speaking, we're in the middle of the flu season, and the number of cases of influenza in the United States, which is somewhere around 22 million, clearly far exceeds the number of cases of novel coronavirus,
COVID-19.
COVID-19 in the US, period. The difference is that we have a countermeasure for flu. If you haven't gotten your flu shot, please go get your flu shot. The flu season isn't over, and we don't have a countermeasure for this coronavirus, and we don't understand enough about it yet to have the same understanding that we have of flu. I would also point out for your friends that in H1N1, the question about quarantine and border control came up. But by the time we knew about H1N1, it was already here. Yeah. What was different about this is that because of improved detection, global surveillance, transparency, all the systems that have been built, we knew about this disease before it reached our shores, and we had an opportunity to do something.
Right, can I just very quickly also, it's the unknown versus the known. I mean, as serious as influenza is, which we take very seriously for the reasons that Nancy just articulated, we know for sure, because we have multiple years of experience, that come March, April, May, that we are going to have the end of the flu season, unless we have a pandemic the way we had in 2009. We don't have that kind of experience with this particular infection. We don't know what its capability is and where it's going. There's a big difference. Even though the numbers favor, my goodness, worry about flu, don't worry about this. The known versus the unknown.
Lady right here, please.
Yeah. Hi, I'm Sabrina Mully with The Hill. How do you, any of you on the panel, think that veiled racism or bias will affect treatment outcomes, especially since there's a lot of misinformation about how this virus came about all over social media? And what do you think health organizations in the US and abroad can do to combat this?
Maybe I'll start.
Yeah.
You know, I heard this story last night that was just really disturbing. I met an Asian gentleman who lives in DC and says that when he gets on the subway, people move away from him. It's startling and frustrating and clearly not the right people to be concerned about the risk associated with. I think we need to try to differentiate for the public the risk which we know of, which is people who have recently traveled to China, especially who are coming out of Hubei province, and not, broadly speaking, every Chinese restaurant in the metro area. And you know, we count on all of you as influencers and as the media to try to get those messages across. So I am worried about the general public. At a healthcare setting, I'm not quite as worried, but I would say that we continue to remind healthcare providers of the importance of asking about a travel history when they treat patients. It should be part of the normal questions that someone asks.
Can I respond to that? I testified before Congress last week about this, and this was one of my key points. And you know, I'll just be very blunt about it. President Trump used his Twitter account in 2014 to spread plenty of hate about Ebola. He should use his Twitter account today to tell people there's no reason to discriminate against people of Chinese origin in this country or Chinese nationals in this country. The virus infects humans, not people based on their national origin and based where they're from. And I think the risk of increasing discrimination in this country against Chinese Americans, against Chinese nationals here is going to escalate as fear fosters this. And so public leaders need to get on top of this and need to tell people that the kind of thing Nancy talked about is the least extreme example. We're going to see kids kicked out of school. We're going to see all kinds of horrible things unfold here in the next couple of months unless we really take a strong stand against it.
There's a lady back there, and then a couple of people up here, please.
Yes, Joan Mietrich, a freelance medical reporter. 2 quick questions. Could you comment on the Imperial College vaccine that they say is almost ready to go into a mouse model? Secondly, is there any protection if you got your flu shot or if you're among the older over 65 that got the pneumonia booster? Is that protective at all?
Before you answer that, can I hijack that a bit and say, is there a model, an animal model yet? Because I don't know that that's been established.
Right. No, it is pretty clear we almost certainly will be able to get an animal model once we get the isolates to be able to do that. I don't think it's going to be very difficult to get an animal model for a coronavirus. But we don't have one that's standardized yet, but it will be coming soon, I think, Helen. You know, there are a number, and I mentioned that I just gave as a prototype the mRNA vaccine that's being developed by the NIH, but there are a number of organizations, including the Imperial College, is going to do the same thing as I described in detail. They're going to take, you know, a couple of months to get it into a human in a phase 1, but they're going to be faced with the same stepwise problem, not problem, but the stepwise process that we have.
But is there global coordination?
Well, CEPI is involved
Yeah,
to a degree.
Yeah, CEPI's involved in supporting certainly the Moderna group, the group that is working with the NIH. When you say global coordination, right now we're going to have global coordination as we always do. We'll have a meeting of the people who are all doing the vaccines, but we're only 6 weeks into this outbreak, so, right.
Lady here with blonde hair, and then the gentleman behind her, please.
Hi, Dr. Susan Blumenthal, former Assistant Surgeon General.
Sorry.
I wanted to ask you about some of the tools that are under development for an effective response. First, is there a rapid diagnostic being developed, like a swab that people can use in doctors' offices? Because right now the diagnostic goes to the state health departments. Two, in terms of repurposing antivirals that are currently, like for Ebola and so forth, that were there, or other ones, are they in clinical trials?
Right.
And three, people are being put into the military barracks or on cruise ships where you have crowding, which is often a place where things spread. What kind of disinfectant is used, and how do we know, how effective is it for the virus?
Why don't you do
But
diagnostics and
can
disinfection?
I just,
I'll do
before you answer
drugs.
her questions, the lady in the back asked about pneumonia shots and flu shots.
Right, there's no reason to think, so it's great to get your pneumonia shot, you should definitely get your flu shot, but there's no evidence that they would have any impact on this virus. And in fact, again, people who have the worst outcomes are in the older age spectrum and with underlying illnesses. You know, in terms of the diagnostic, clearly a rapid diagnostic that could be used bedside is where we want to get. But I do think that we should appreciate the tremendous accomplishment of, we're talking about a pathogen that wasn't identified until early January, and we already have a PCR out to our state health department partners incredibly rapidly, something 10 years ago we never would have seen. So I think that's an incredible step. What CDC has done is make that PCR available, not just to the states, but making our prototypes available. But we've also taken the virus and isolated it, put it at the NIH's BEI resource so that other academic and industry partners can use it for research as well as for development of new diagnostics. And FDA has also put that pathway together. So certainly bedside diagnostics, that's, you know, hopefully where we'll be. It's not where we are today.
Repurposed
drugs, repurposed drugs. When you get a new pathogen, you either repurpose drugs you already have or you do targeted drug development. We've started targeted drug development, but the repurposing has already started. Remdesivir, which is a nucleotide analog, which, as you might recall, was one of the 4 limbs in the Ebola study that didn't show that it worked very well with Ebola, has some in vitro and model work, as well as some empiric use during SARS, which was felt that maybe it had some effect. It has now been initiated in 2 trials in China, which are randomized controlled trials, standard of care versus standard of care plus remdesivir, in 500 patients in each trial with advanced disease and with less advanced disease. That's just one. Right now, obviously, people have been talking about anti-HIV drugs such as Kaletra, which is a combination of protease inhibitors. So there are going to be trials, but one has actually already started, the remdesivir.
And the last question, I just want to comment that I guess I want to thank the military for their flexibility and partnership in finding places to house these people. But it would be a mistake to assume that they're in a barracks in the way that we see it in World War II movies, everybody, you know, with cots. These people are housed in a way that allows them to be housed separately. And so that the military bases is actually specifically chosen because it allows us to house people in a way that there's not so much opportunity for transmission. That being said, there's no reason to think that regular disinfection wouldn't work. We have guidance for that on our website. And also now that the virus is available through the NIH resource, some of the first studies that are going to be done are looking at the survivability of the virus on various surfaces as well as some of these questions.
Gentleman there.
Yes, Dr. Michael Duenas, Chief Public Health Officer for the American Optometric Association. I was formerly at CDC. I appreciate you. And thank you for the three of you for rapid deployment here for this meeting. But one of the questions I have is that you talk a lot about the death rate and not much about secondary attack rate. And that's very important. We've seen secondary attack rates reported from 1.5 to 3.5, and now yesterday there was a report of 4.1. And that's really how fast it's transmitted through the from person to person. Could you talk a little bit about that and how you're monitoring that?
So I think what you're really talking about is the R naught. So the R naught is a fancy word that is meant to explain how contagious something is. If I have the disease and I transmit to 2 people, my R naught is 2. For comparison, measles, which is among the most contagious of infectious diseases, has an R naught around 14 to 16. Most studies have said the R naught for this is somewhere around the 2 to 4 range. It is a question that everyone wants to know. It is important. I'm not sure that it dramatically changes things. And one of the problems here is that people are rushing to get their data out, which is a good thing. But sometimes it's hard to make sure that all the data has enough peer review to make sure that we know how to interpret it. It's hard to tell in some of the studies if the patients overlap. And it's also hard to know that all of the rigorous science has gone into every one of those investigations. So we're looking at R naught in 2 populations. We're looking at it in China, where there's such an overwhelming number of cases that I suspect it's hard to track. And then countries that have had smaller numbers of cases are looking at their clusters. And that's where a lot of this data is coming from. And the question really is, are what we're seeing outside of China completely reflective of what we're seeing inside China? I don't think we know.
Right. Question right here, please.
Hi, thanks. Dan Glickman. You guys are just amazing. That you really give us a lot of trust. This pathogen seems to have come from animal transmission to humans. I don't know that for a fact, but that's what I read. They had these live animals in these markets in China, and so many of these viruses seem to have kind of a zoonotic basis to it. They start from animals. The Ebola thing apparently had this as well. Is this accurate? And what are you bringing in researchers from the Department of Agriculture and the people who produce animals? Because if most of these diseases come from animals,
join the fray, Dan.
Yeah, shouldn't that? Is that something we should have in terms of our domestic policy as well? This animal to human contact.
Well, the answer is, if you look there, this is the 3rd coronavirus that we've dealt with that went from thinking it was just a common cold, because there are 4 coronaviruses that account for anywhere between 10 and 30% of the common colds. But there's a whole bunch of other coronaviruses that infect animals. If you look at SARS, through a lot of investigation, it was felt that it went from a bat to a civet cat to a human. And civet cats that are used as, they're very exotic animals used in feasts that people have, who various feast days, they do them. Then we had the Middle East respiratory syndrome, or MERS, which was felt as showing that it went from a bat to a camel, from a camel to a human. So that even though we don't know a lot, we don't know about this, that it is likely that way back somehow, this was a jump species. It went somehow from a bat to some sort of an animal. That's why they thought the market was where it came, even though that was not the case. People were infected before the market thing came up. The short answer to your question, Dan, it is highly likely that this was a zoonotic that jumped species, because if you look at the phylogenetic tree of bat viruses, they are really quite similar to the coronaviruses. They're in the same category. In fact, if you look, the phylogenetic trees go like that, and this is bat, and this is the coronavirus in human. But and part of your second part of your question is yes, obviously, we're looking at the interface, and we use people who are experts in following animals over a period of time. We see this with influenza, where you have the proximity of people and pigs and ducks and chickens, and that's how you get the jumping of species. When you have customs that go back for centuries of people who go to wet markets and interact with animals that are exotic animals, you're going to see these kind of things.
Gentleman there, and then the lady there, and then I think we may have to.
Irving Lurch, physics community. Sorry. This morning in the New York Times, there was an op-ed piece by Professor Leung from the World Health Organization. He addressed a number of the issues that the panel has been covering here. He raised a couple that I would like some clarification about. He talks about SARS, for example, and he said that the initial outbreak led researchers to conclude that the infection rate, the mortality rate rather, was between 1% and 2%, but that when epidemiologists did the statistical modeling, they came up with a horrendous figure of 17%. Dr. Fauci mentioned a somewhat lower figure, but it was still very high. Nonetheless, SARS eventually died out, and it's no longer considered a problem. The question really is concerning our experiences today. We have 43,000 cases in China, 1,018 deaths. We have something like 400 outside of China. There seems to be a disparity in how we perceive the relative frequency of mortality in these populations, and though it's clearly very, very early, the question is, do we see any differences?
Any differences
In what?
between what and what?
Between the manifestation of the disease outside of China and in China.
Yeah, Nancy could answer that, but I think it's too early to really say anything about that. There are too few. If you look at the, close to 300 or more versus 40,000, the N is too small for the outside of China.
Yeah, just a comment about the drug companies and their reluctance to invest in vaccine development. They make a hell of a lot of money on other things like opioids, and without any conscience. And the other thing is they also benefit from the research that NIH does, where the NIH develops drugs, and then it gets passed on to the drug companies, and they make fortunes.
I think I saw a hand right there, and then we may have to end this. And somebody please tell me, we're at almost 1:20. Okay. Okay, thank you.
Richard Coleman, retiree. I go to Taiwan frequently. A face mask is like a fashion accessory there. And I read in the Taipei Times that because the Chinese were looking for 100,000 a day and they only had 30,000, there was a real shortage of face masks, but they didn't want to ask Taiwan for political purposes. Number one, are we doing anything? I mean, this would be an act of great friendship. I don't know if a relationship would allow that for us to make masks. But number two, do they do anything? Are they worth even putting on?
How about?
Do you mean, are they worth putting on now here?
No.
Are they ever? I mean, face masks are incredibly effective when they're used appropriately. So the best way, frankly, to use a face mask is to put it on the person who's sick. Yeah. Because source control is actually the best way to protect everybody else in the community. And we certainly have robust measures that we put in place in healthcare settings because we want to make sure that our healthcare workers are protected, since of course that workforce is essential for us to be able to respond. But right now in the United States, am I recommending that people go out and buy face masks? No, I think that would be the wrong way to proceed right now.
There was a gentleman way at the back who's been trying to ask a question, and then that'll be the last, I'm afraid.
Thank you. My name is John Osthouse. I'm a retired government employee. I was wondering, what is the status of an effort, if there is an effort, to submit an emergency supplemental to the Congress to get the funding that you're going to need to combat this problem?
I guess let me start by saying that, one of the things that was new for CDC at this outbreak was the availability of emergency response funds. And that really was a game changer for us. Frequently, when we have large crises like this, we have to wait for funds to be available, and it really impacts how quickly we can respond. It made a huge difference in this outbreak because remember, we're talking about something that we didn't know existed before 6 weeks. We've had to move incredibly quickly, and the availability of those resources allowed it to be seamless and rapid, and we're grateful for Congress for making those funds available.
Yeah, I mean, in fact, if you remember back in the Ebola day, Tom Frieden, who was the CDC director at the time, and I were very public about wanting to have that kind of fund, and the fund was given $100+ million, which the CDC is very well using right now.
Right, if I could just add, I absolutely agree that the creation of the funding last year by Congress of this emergency fund is a tool that the responders have that we didn't have 5 years ago, but that's not going to be enough. And I think that, again, particularly if we have more introduction of the disease in the United States, more state and local resources being pulled down, more resources in our healthcare system being pulled down, the administration is going to need an emergency supplemental. And by the way, that's a challenge on both ends of Pennsylvania Avenue. So on the one hand, I hope that someone at OMB is getting ready now to send this thing to the Hill and starting to really pulse the agencies for what they need. And I hope Congress is getting ready to act quickly. We were very fortunate in 2014, President Obama sent the emergency supplemental to the Hill. Congress passed it in 4 weeks. The next year, 2 years later in 2016 with the Zika response, it lingered up there for months before Congress acted on it. So yeah, I think let's just be fair here. I think there's a challenge for both ends of Pennsylvania Avenue. The administration needs to get this ready. Congress needs to be ready to act quickly when the administration sends it up.
So I think we're going to have to leave it there. Please join me in thanking these people for giving you so much time. Thank you.
Great job.